Hello, my name is Cassie Haro, and I will be presenting on limb-girdle muscular dystrophy. I will begin with an overview of the biopsychosocial spiritual understanding. Limb-girdle muscular dystrophy, also known as LGMD for short, are a group of inherited muscle disorders with a common feature of limb-girdle pattern of weakness. They are caused by over 29 individual genes, and the condition causes atrophy and weakness of the shoulders and the pelvic girdle musculature. LGMD affects men and women and may be inherited in an autosomal dominant or recessive fashion with varying severity and age of onset. The autosomal dominant LGMD1 represents approximately 10% of the LGMD that tends to have an older age of onset and has a slower progression. The recessive gene have a younger age of onset and relatively faster progression and are by far the most prevalent form of limb-girdle muscular dystrophy. As I stated, more than 29 different subtypes exist of this condition. They are inherited and typically can present in childhood and adulthood and have varying degrees of progressiveness. The dominant LGMDR1 is the most frequently observed subtype, followed by recessive LGMDR2. I will focus on LGMD1 for this presentation. Symptoms that are frequently reported are exercise intolerance, calf and tongue hypertrophy, tiptoe gait patterns, a scapular wing, and scoliosis of the spine. Patients may report fatigue when reaching up or inability to lift objects over their head. Current treatments focus on management of symptoms and preventing and addressing complications that may come up. Among patients that are living with this condition, uncertainty about future health, physical and mental struggles to adjust continually to progress deterioration, and dealing with a lack of knowledge of the condition by professionals in the society exist. Most important for clinicians is the variation in the dominant and recessive inheritance and the impact that the various subtypes may have on the heart and lungs. Individuals may first notice a problem when they begin to walk and feel weakness in their hip and leg muscles. They may have trouble getting out of chairs, getting up from the toilet, difficulty navigating stairs, arm fatigue and difficulty lifting things over their head, and also just muscle atrophy, just wasting of the muscles. Depending on the subtype, patients may develop respiratory failure later during the course of the disease, and also heart conditions may progress as well. Currently, there are no altering therapies that have been approved by the FDA, and the standard treatment for this condition uses a multidisciplinary clinic model, but recessive conditions are potentially open to gene replacement therapies, which are already being tested in clinical trials. Living with a rare degenerative disease such as limb-girdle muscular dystrophy affects all aspects of daily life, from work to personal and family life. The burden is not only just physical, it's also emotional and social and economic as well. It leads to difficulty walking, inability to carry out activities, social role limitations, emotional distress, and lower extremity weaknesses. Current treatments focus on the management of symptoms and preventing the condition from worsening. In a qualitative study by John et al. 2002, where 20 adults with this condition identified issues that had the greatest impact on their quality of life, and the most common theme were mobility and an inability to carry out activities that they liked. Also, just social role limitations, emotional distress, and the need to utilize adaptive equipment such as a wheelchair to assist with mobility. And also just uncertainty about their future health and the mental struggles that come with that. Caregivers' lives are impacted by the disease by way of their evolving roles as caregivers as the disease progresses and a desire to have their loved ones live a happy, full and happy life. The changes from being independent to becoming in need of support from other persons and assisted devices to manage daily activities has been described as a psychologically trying process among adults. Experiences of progressive functional decline that influence identity, social status, and social relationships. It's difficult to do anything spontaneously. Everything has to be planned. Also, inaccessibility in society, with public buildings, shops, and restaurants, or even just visiting family and friends' homes. They have to take into consideration bathrooms that are in the home if they need to use the restrooms, and difficulty navigating that. And although wheelchairs can be perceived as providing a new sense of freedom, the transition from walking to becoming in need of a wheelchair can be a psychologically distressing process. While physical themes are most prominent, patients also report a high frequency of social limitations, cognitive difficulty, and impaired body image and social role dissatisfaction. All this leads to dissatisfaction in social situations. The spiritual dimension is a significant component of the experience of a chronic degenerative illness. Having a personal relationship with God, believing in an afterlife, and contributing to a faith community are expressions of religion and spirituality. Although religion can be one way an individual expresses his or her spirituality, it's not the only way. Manifestations of music, art, and nature have been linked to expressions that serve that are meaningful and connect the individual to a higher power or energy force. Spiritual improvement in patients' life can also be spirituality improves patients' life by reducing the level of anxiety and depression that an illness like this can cause. Spiritual closeness of patients with chronic degenerative illnesses has a positive impact also. If a patient finds resources in spirituality that bring higher meaning to their life, provides inner strength, and psychological, and can contribute to them becoming closer to others, can be helpful. Moving on to the clinical vignette. Janet is a 53-year-old American female diagnosed with limb-girdle dystrophy. At age 30, she was diagnosed with limb-girdle muscular dystrophy 1, which shows a later onset and has a more gradual progression compared to other subsets. Janet has been divorced for 10 years and is the mother of 2 daughters, ages 21 and 16. She does not receive financial assistance from her ex-husband, nor is he connected with their daughter. Due to the high cost of healthcare, Janet has continued to work as a 3rd grade teacher to be able to keep her health insurance and pay for healthcare needs. Her employer provides the appropriate ADA compliant resources she needs to perform her duties. Recently, Janet's condition has caused increased atrophy and weakness of the shoulders and pelvic girdle musculature, and she's having trouble getting out of chairs, climbing stairs, and needs assistance when using the restrooms. Janet's doctors are concerned with her risk of falling and have recommended that she transition to a motorized wheelchair to assist with mobility. With the progression of symptoms, Janet reports an increase in her stress level due to the mounting financial cost of making her home wheelchair accessible and the additional responsibilities on her daughters to make her feel, the additional burden on her daughters makes her feel like she's a burden. Sally, the eldest daughter, holds a parentified role in the family. She became the primary caretaker to her mother and younger sister when she was 15 years old, around the time when her parents divorced. The family enmeshment has her feeling overwhelmed, stuck, and unable to live her life. During this time, the younger daughter, Kathy, has developed anxiety and obsessive compulsive tendencies. She complains of stomach issues and has been absent from school many times this year, and as a result is struggling to pass her classes. The family maintains a strong Taiwanese influence in cultural tradition and language. They align with the Christian faith, but due to Janet's medical condition and trying to keep up with the household chores on the weekends, they have not maintained regular attendance at their church. Case conceptualization. In Rowland's typology, onset is gradual. Janet's condition of muscular dystrophy 1 is an inherited autosomal dominant gene mutation with an older age of onset. The disease typically manifests during the second or third decade of life, with variations, variable progression towards disability within the next 20 to 30 years. Diagnosis was determined by a family health genogram, a muscle biopsy, and genetic testing to achieve the final diagnosis. At age 30, after the birth of her second daughter, Janet noticed weakness of shoulders and arms and fatigue. She was unable to carry her newborn baby for a long period of time and relied on Sally, the eldest daughter, for assistance. The course is progressive. Limb-girdle muscular dystrophy 1 manifests during the second or third decade of life with variable progressions towards disability over the next few decades. Janet also reported a high frequency of social limitations and cognitive difficulty, including emotional distress, impaired body image, and social dissatisfaction. The outcome living with this condition involves uncertainty about future health, physical and mental struggles to adjust continuously to progressive deterioration, and dealing with a lack of knowledge of the condition among professionals and society. The family is concerned about the disease progression and the impact and cost of coping with the ever-changing physical needs that Janet will have to live. I chose structural family therapy because it is mindful of the multicultural approach and is respectful of integrating traditional elements essential to the family system. In the early phase, the therapist will join and accommodate the family rules, patterns, and structure. The client is of Taiwanese American descent, and her multicultural experience will be respected and integrated in all phases of goals. The therapist will begin therapy by developing a strong therapeutic alliance with the client by affirming the client's feelings and being empathetic. The therapist will demonstrate this by reflecting back and validating client's response. In the middle phase, Sally has assured the role of the primary caretaker. Sally has assumed the role of primary caretaker and parent to the family structure, and it is imperative to improve hierarchy within the family. The therapist will gently challenge assumptions within the family subsystem, provide psychoeducation regarding family patterns and development issues for the purpose of initiating boundary-making strategies. The end phase goal, Janet will maintain the goals that she has achieved in therapy. Janet will integrate appropriate exercises for improving muscle strength, joint mobility, to delay the progression of the disability as much as possible. The family will continue with individual and family therapy to address progressive illness and anticipatory grief. The therapist will support the client in reframing challenges, experiences, and situations into opportunities for growth. In conclusion, family functioning requires effective organization to maintain integration as a family unit, to foster the healthy development of its members, and to master challenges over the life cycle. A flexible structure, connectedness, and social economic resources strengthen family resilience, according to Rowland, 2018, page 77. These are my references. Thank you.